I've got it.
Sorry. Maybe phone is a pen there. And then I'll get it back for the last guy. Oh no, that's Tom, I have to take that. So what I'll do is I'll take this over. Can I get started?
Yeah, okay.
And I'll hand it to you when I come back.
Leave it over there.
We'll leave it over there.
Yeah.
Right,
Yeah, that's right. Thank you.
Good afternoon, everyone, and welcome back to this very exciting session we have for you now this afternoon. It's called the International Society Session. And DAS, for the last decade, have been interacting more and more with our colleagues in the other airway societies, the Society of Airway Management in the States, and also with the Australian SIG and European Airway Management Society. So we have three excellent speakers for you on this session this afternoon. And the first speaker is Dr. Kamal Tolga, who is well known to DAS. And Tolga studied medicine in Istanbul, and he did his training in Marmaris, and he's a clinical professor of the academic university there. But then he moved to Qatar last year, where he works in the Hamad medical group, and he's a clinical professor in the university there. He's very interested in cardiothoracic anesthesia. He was VP of the European Airway Management Society, but now he is the incoming president, and I think he's due to start his presidency in January. He has many publications on various aspects of airway management, but today he's going to talk to us about the physiological difficult airway. Thank you, Tolga.
Thank you, Ellen, for these kind words. Good afternoon, everybody. So my name is Kemal Tolga Saraçoğlu. So I'm really proud and pleased to represent the European Airway Management Society here. And I would like to thank to the organizing committee, the conference chairs, co-chairs, and also, of course, the DAS president for having me here. Well, I would like to cover this session about the physiologically difficult airway. I have no conflict of interest to declare, and my objectives will cover these questions. So what is unique for critical air patients, and what are the physiological changes behind them, and which patients may deteriorate, and what says the guidelines and the recommendations about it. So we are in a DAS meeting, and I would like to start with a DAS paper, which was published last year in 2022. And the analysis of the anatomically difficult airway. I would like to here just start with a comparison with what happens in the anatomically difficult airway and what happens in the critically difficult airway. So according to the results of this analysis, the airway-related critical incidence was about 11% in this series of 675 patients. And the most important advanced outcomes were related with the unexpected admission to the hospital, unexpected admission to the ICU, or bleeding, or dental trauma, etc. And this paper was published, this meta-analysis was recently published this year about the critical care patients. As you can see, the measured adverse events incidence increased about 3 times higher. The incidence rate was 30.5%, and the intubations especially complicated by hypoxia in 15%. The cardiac arrest occurred in 2%. In the DAS paper, it was 0.3%, about 7.7 times higher incidence was here in this meta-analysis, and the cardiovascular collapse was 18%, was recorded in this study. I'm sure you are aware about the INTUBE study. So almost 3,000 critically ill patients were studied in this paper, in this analysis from the 29 different countries undergoing the tracheal intubation, and at least one major critical event incidence was about 45. Almost half of the patients had the major clinical incidence during the tracheal intubation in the ICU, and the cardiovascular stability incidence was 42.56, and severe hypoxemia 9%, and here the cardiac arrest incidence was 3.1%. In different studies, so the range changes between 1% to 7% about the cardiac arrest incidence. So let's see the reported reasons for the cardiac arrest, especially hypovolemia or hemodynamic instability are the major factors, and it is followed by the hypoxemia in critical ill patients. So the other complications are included, are related with the esophageal intubation. Also, there's a high risk for pulmonary aspiration for these patients. Let's continue with the anatomically comparison with the anatomical and physiologically difficult airway. So it is most of the time it is easier to anticipate because we have some marks, we have some pre-evaluation checklists. So we are examining their mouth opening, so the facial hair, the neck circumferences, and we have some mnemonics. So about the difficult intubation, difficult mask ventilation, even for the difficult video laryngoscopy or phono. And if it is difficult, it was difficult previously, 5 years ago, 10 years ago, you are expecting that it will be again difficult today. But when we look at the physiological difficult airway, so there are dynamic factors included. So even it was yesterday, it was easy, but because of the physiological dearrangement, today if the patient needs reintubation, so it may be difficult again. And there are some also some difficulties to anticipate them. Yes, we have the Macoca score, but when we look at the Macoca scoring, so again, you have to evaluate the mouth opening, malempathy scoring, or you have to ask questions about OSA for a patient just before the tracheal intubation in the ICU. It is really limited. So the skills of the operator is a really game changer. So if you are good at fiber optic skills or video endoscopic skills, you can come over, you can solve most of the problems. But it's not the same in the ICU. And we are trained and we are experienced just inside the operating theater, usually, where it is a controlled and safe environment. So the patients are pre-evaluated, patients are pre-medicated and fasted. And if there is any problem, so you can delay the case, even you can cancel the case. But it's not the same for the critically ill patients. So if you abort the mission or delay the mission, so this means that you let your patient die. So you have to proceed anyway. And there are some varying differences of decompensation because of the comorbidities. And yes, you are still very good at skills in fiber optic or video endoscopic techniques. Even your first pass success rate is high, the patients can be deteriorated after tracheal intubation because of these physiological derangements. So this is a nice summary about the characteristics of the physiologic difficult airway. We can determine in 4H. The one is hypoxemia, hypotension, the increase of hydrogen ions as in metabolic acidosis, and the heart failure. So you have to be sure that you have to know the right ventricular function before you proceed, before you intubate your patients inside the ICU. So as you can see, it is more than physiological difficult airway. Most of the time, the anatomically difficult airway is a plus, and a situationally difficult airway is another plus because of the situation, because of the properties of the patient, the fluid resuscitation, capillary leak, or because of trauma, burn, or infection, etc. It's a nice fishbone diagram about the contributing factors that are related with the harm in the airway management. So the problem starts from the beginning, from the preparation. Preparation is even difficult for these patients. Pre-oxygenation is difficult. Even you pre-oxygenate adequately these patients, during the apneic interval, they can deteriorate easily. So all the human factors, all the environmental factors, all the equipmental factors are coming together to force you to fail during the tracheal intubation in the ICU. As you can see, the incidence is quite high, about 10 to 30% of failure incidents was reported inside the ICU. There are 4 physiological factors. So first of all, we give them the induction agents. So, and most of our induction agents, as you very well know, they have the effect of vasodilation, and we depress the sympathetic discharge, sympathetic tonus. So we cause hypotension, hypovolemia, or the decrease in the systemic vascular resistance, in the stroke volume, and the cardiac output. The second one is the interval, apneic interval. So as I mentioned, even you pre-oxygenate very well, they are very prone to hypoxemia and hypercarbia. So if this occurs, this means that you increase the pulmonary vascular resistance, increase the hydrogen ions, both in respiratory and the metabolic acidosis is on this stage. Another thing, if your patient is not well prepared, so this means that during the airway manipulation, a sympathetic discharge will be on the stage. That will increase the systolic mean arterial pressure, heart rate, and also the intracranial pressure. Think about a neurological patient, so it will be also catastrophic for our neuro patients. Well, another thing is we are shifting from negative pressure to positive pressure. So as you very well know, during the physiological ventilation, during inspiration, the transpulmonary pressure is getting negative, and this accordingly, so two things happens. The air is coming from the upper airway inside the alveoli, and it lets to pull the blood inside the IVC and SVC. So this increases the preload and the stroke volume and the cardiac output. But after tracheal intubation, when we start the PPV, so we just oppositely give the positive pressure, so create a positive pressure environment inside the thoracic cavity and just block the pulling the blood inside the inferior and superior vena cava. Yes, there are risk factors also for the peri-intubation hypotension. If 1 hour ago the mean arterial pressure was low, it means that most probably it will be low after tracheal intubation. Shock index is important here, I will mention later. So if you are intubating for the acute respiratory failure or chronic renal failure, so the risk factor also for the geriatric patients is another risk factor. This is a nice summarizing picture about the cardiovascular collapse during tracheal intubation. The contributing factors, as I mentioned, the potential solutions are given also here. As a drug, as an induction drug, so the ketamine and etomidate are the recommended agents here for the pre-intubation hemodynamic stabilization optimization. So the fluid bolus can be given, or if your patient is not responsive, the preemptive use of the low-dose vasopressors are recommended here, and after tracheal intubation, low PEEP, low tidal volume are recommended. So these recommendations are coming from Society of Critical Care Management. So this society also recommended to use as a neuromuscular blocking agent SAX or rocuronium, and as an induction agent, they recommended to use as the etomidate. And they declared that the etomidate cannot increase the mortality rate or the use of the pre-intubation vasopressor incidence, they cannot increase. Why they declared like that? Because there are a lot of studies against ketamine, or especially against the etomidate. This study was EVK trial group, was performed by them, last year published, so they declared that etomidate, if you use etomidate, when you compare with the ketamine, the mortality rate increases. And this meta-analysis was recently published this year. They again declared that when you use etomidate, the mortality rate slightly increases in the critically ill patients. Well, we have limited drugs, so we have limited choices. First of all, if you are giving the hypnotic agents, what is recommended to give the neuromuscular blocking agents in a full dose? So this is important here. And etomidate and the ketomidate can be chosen according to the contraindications and according to your patients. But propofol is not recommended because of the hemodynamic compromise in these patients. But it's not always the same in the reality. When we turn back to the INTUBE study, so you can see that the most frequently used agent was propofol in 41% of the patients, and the second agent was midazolam. In 77% of the tracheal intubation patients inside the ICU, they didn't use any ketamine or etomidate. Maybe this was one of the reasons of the high adverse outcomes. So norepinephrine is preferred if your patient is pre-intubation in a shock situation or deep hypotension. So, but again, in the intube study, the vasopressors or the fluid boluses, fluid challenge, did not reduce the occurrence rate of the cardiovascular instability or the collapse. After that, after 1 year, the PREPARE 2 trial was published, and they again mentioned that when you compare with the patients, the fluid boluses did not change the mortality rate. So it should be a tailored approach according to the patient's need and what is recommended here. So if possible, assign one of your colleagues for the hemodynamic stability to observe during the tracheal intubation and to give the drugs, administer the drugs, or manage this situation apart from the tracheal intubation, apart from the airway management. These are the some recommendations. So they mentioned the shock index. If your patient's shock index in the pre-intubation period higher than 0.7, so these patients can be one of the candidates for the fluid boluses, or if they don't respond, if they are not volume dependent, so you can consider about giving the vasopressors before tracheal intubation they mentioned. Well, let's shift to the apneic interval. There are some physiological changes, so the reduced FRC is one of them. VQ mismatch, shunt, atelectasis, and the increased death space are the reasons for the high risk for rapid desaturation in critically ill patients. That's why we need advanced methods of pre-oxygenation required. And according to the studies, 19% to 70% of incidence there for desaturation. And the shunt physiology reduces the efficacy of pre-oxygenation even if you use together with the apneic oxygenation techniques. Well, this is a nice summary about the management of pre-oxygenation according to the PF ratio. So if your patient's PF ratio is between 300 to 200, you can easily back valve mask, you can easily apply back valve mask ventilation with or without PEEP application. High flow nasocannula oxygenation is recommended here during the whole procedure. If your baseline PF is between 200 to 100, around 150, so non-invasive techniques, non-invasive positive pressure ventilation is recommended here. And if you have a really sick patient, less than 100 PF ratio, the recommendation is not to give them the neuromuscular blocking agents. Just go for the awake techniques. Optimask study, they declared a new technique. They used the high flow techniques with the face mask ventilation, high flow 60 liter, together with the face mask 15 liter, and they concluded that they had more better outcome for these patients. Sometimes refractory hypoxemia is on the stage, even you use the high flow techniques or PEEP. So INO is recommended here because they induce the local vasodilation on the alveolar capillaries, and they improve the VQ mismatch and the oxygenation. Sometimes we have the combative patients or delirious patients. According to the studies, dexmedetomidine or ketamine-induced facilitated pre-oxygenation is recommended for these patients. Yes, we have the DASC guidelines. In the DASC guidelines, I'm not going deep, but three important facts were mentioned here. One of them is the declaration of failed intubation. If you don't declare, one of the team member doesn't declare, so the operator will continue to do it more than 3 times. And after your first failing, so you have to consider exactly the video laryngoscope, and you have to be prepared before, after your first fail, the FONA techniques should be ready inside the you had to prepare for the FONA early, and the vortex approach was mentioned here to be used. There's not a direct recommendation to start with the video laryngoscopy because of the limited data in the literature. So they're just saying that, yes, according to the operator's choice, you can start with video laryngoscopy. But if Mococo is higher than 3 or equal to 3, you have to start with the video laryngoscopes, because we know that video laryngoscopes increase the first pass success rate. Even in this trial, so this year published in NAJM, so the first pass success rate by using the video laryngoscope was 85, less than 90%. And we assessed what's happening after pandemic. So we realized that, yes, most of the centers have now the video laryngoscope after the COVID-19 pandemic. And most of the centers increased their rate to use routinely in all patients' tracheal intubation. So we have to be experienced in video techniques before having any catastrophic outcome. And we have to learn from our past. Yes, unfortunately, I will turn back again to the Intube study. The 81% of the patients were not intubated with video laryngoscopy. Just direct laryngoscopy was used at the first attempt. Only in 17 patients, video laryngoscope was used here. So as a take-home message, there's not a one-size-fits-all approach for the physiologically difficult airway management. So there remains considerable ambiguity in this arena, and a tailored approach is the key factor to manage their airway. If possible, you can assign at least one member to monitor the hemodynamic status. And you have to plan for the failure because the failure rate is quite high for these patients. You have to have a triggered transition to phono. Just remember the vortex approach, and identification of the cricothyroid membrane and using the POCUS for the gastric fluid volume is recommended. And I know there's as you can see, there's a debate among the drugs, but you should have a standard protocol in your institution, and you should follow it during this management. So in my last slide, I would like to invite you to Istanbul, Turkey for the next year's EAMS conference. It will be, please save the date, 25 to 28 September 2024. Thank you very much for your patience.
Thanks, Prof. Tolga, for a wonderful talk. I'm Rajneesh Sachdeva, one of the anesthetic consultants at Queen Elizabeth Hospital in Birmingham and a co-chair for DASH 2023. It gives me an honor to really introduce the next speaker, who's the president of the Society of Airway Management. He's a pediatric anesthetist, and he has got interest in patient safety and improving the quality and the safety, and he's done the doctoral thesis on that. We know him from having invented the ORSIM, which is a bronchoscopy simulation, and he is presently involved in the airway lead, setting up an airway lead network, which he did in New Zealand, and he's doing that in US. He's going to talk about what's new about CICO and ePhona in 2023.
Meters deep in the quarter-final against France here last Sunday night. And here he is from 49 meters to win this semi-final. Andre Pollard.
Sorry to show you that, but I have a point. That was Andre Pollard, who kicks for the Springboks. And in the recent Rugby World Cup, he achieved 100% success. Now, in sport, 100% success could mean the difference between winning the Rugby World Cup or not. In medicine, it means a heck of a lot more. In the context of emergency front of neck airway, less than 100% could mean death to the patient. So we need to strive for 100% success. In this recent study, of ePhoner in the community, emergency front of neck airway, the clinicians achieved a median 100%. So here's my conflicts of interest, and none of it is relevant to what I'm going to say to you this afternoon. This afternoon, I want to talk about pre-hospital phoner, pediatric phoner, pediatric recommendations, some phoner skill decline, and I'll finish on some human factor issues. There is a lot of literature being published about phoner in 2023, but I've picked out these 5 which I think might be of interest to you. So getting back to that paper I've just shown you in the community, it was a systematic literature review of phoner, and it wasn't included pre-hospital patients. And there were 69 studies, and they ended up looking at 1,229 patients, and it had an overall mean phoner success rate after 2017 of 100%. Now that 217 is very relevant because that's when a guideline came in promoting a scalpel bougie technique. Prior to that, there were also a number of patients having needle crocothyroidotomy and some having kits applied as well. So the pooled overall success rate, including those other techniques, was 88%, and surgical techniques, when they took that out separately, was 100% success. Needle success was 50%. Now, I'm not aware of any hospital series like this, and certainly I've never seen success rates of 100% coming from our hospital. So we need to ask the question why, and how maybe we can achieve those lofty heights. So the conclusion of the study was that the phoner success rate is high, and this was in the community, remember. Surgical techniques for phoner appeared to be more successful than needle techniques, and it supported the UK guideline, the 2016 and then 2017, so the DAS guideline and then the community guideline. And also they mentioned that the more research is required to determine the most effective pediatric phoner technique. Now, there were only 29 cases of pediatric phoner in this series, and the biggest series, which I think was 22 patients, they didn't record which technique was used. So we really are still lost in determining the best technique. This isn't the first time we've heard very impressive results coming from community ePhoner. So this is David Lockie's group, and it's the London Air Ambulance Service. And they have a doctor-paramedic team, and in this series they attended to 28,000 patients, and there were advanced airway management to 7,000 patients. That was about a quarter of all the patients they looked after, and 48 of those ended up having a scalpel bougie technique with 100% success. So David Lockie was interviewed by the BJA in a podcast, and he was asked what were the keys of success. And he said, number one, you need a positive mental attitude. You can't go into it half-baked. Number two, equipment has to be immediately available. Number three, a trained paramedic assistant is present at all time. Number four, the procedure is relatively simple and it's their standard operating procedure. They don't have alternatives. So I visited David Lockie and he took me out to his helipad on the top of this building on a very windy day, and I was utterly terrified. But he also took me inside and showed me their training room and explained that they regularly train. In fact, all their downtime, a lot of it's devoted to training. And when they go out, they adopt these simple keys to success. So that's their secret. Another thing I want to bring to your attention, if you weren't aware of it already. Now, this is old knowledge, but it still seems to be a persistent problem. And it comes from the ASA closed claims study. They found in over 60% of cases where there was a SECO event, a surgical airway was obtained. but it was too late to avoid a poor outcome, that being brain damage or death. So it seems to be one of the issues between us and community e-phoner is the rapidity with which we get on with doing the e-phoner. That delay can end up being fatal, and that's something I think we should attend to. Now, I know there's been a lot of discussion today about paediatrics, but I do want to touch on this in terms of paediatric e-phoner. And here's another study that came out very recently. In fact, this was only just recently, and it was an early view in pediatric anesthesia. And it's a crossover study looking at two different techniques to do a surgical airway in infants and neonates, and they use a rabbit model. First of all, they position the rabbit, they put a head on it to make it look more realistic, and they have blood available. But the two techniques, there's one on the right, that's a rapid sequence tracheotomy. Basically, it's a longitudinal cut. Then the skin edges are held apart by towel clips, and then there's a longitudinal cut with a scissor through 3 tracheal rings, and then under direct vision, a tracheal tube is placed. The second technique was a scalpel bougie tracheotomy. Very, very similar technique, same idea, do a longitudinal cut, pull the tissues apart, but this time they put in a bougie and railroaded a tracheal tube over the top. The outcome of the study was that the scalpel bougie caused less trauma to the airway, was a little bit faster, and it was favoured by the participants. Now, you may be familiar with this paediatric anatomy, but basically an infant and a neonate, the larynx is higher in the neck. So if you're trying to approach through the cricothyroid membrane, which you shouldn't do that, but if you were wanting to put a needle through there, you would probably have to go angle your needle cephalad. And also, if you are trying to approach through the cricothyroid membrane, the cartilages of a pediatric larynx are very soft and very prone to damage. So the approach is a tracheotomy. That's compared to adult airway where it's much lower in the neck. Now, my next slide shows a very brief video, and this was given to me by Thomas Engelhardt, and it's a picture of a baby about to have an elective tracheotomy. So they put a bronchoscope through the vocal cords with a camera on it to film it, and an anaesthetist attempted to put a needle into the baby's trachea prior to the tracheostomy. And you can see the degree of collapse that's happening and how compliant that trachea is with the approaching needle. The other startling result of this video I found was, where's the needle? And in fact, it doesn't go on much longer, but you never actually see the needle. The needle doesn't enter the trachea. Now, I accept in some cases it will do, but it's not that easy to place a needle into a very compliant tissue. And the other thing is, if you are successful in getting the needle in there, what do you do with it next? And we've done a recent study on this and looked at the options. And it's already been said today that jet ventilation is inherently dangerous. And all these other Y connectors, you don't really know how much pressure or volume you're delivering. So we measured those and we found all of them were excessive, apart from one or two which were woefully inadequate. And the only device we found that's acceptable is the Ventrain, the bottom left corner there. But unfortunately, the company that make the Ventrain has gone out of business. So there aren't many options to safely ventilate through a needle that you put into a baby's trachea. And the one that's absolutely deadly, and it's still being quoted, is the three-way tap, because that's a one-way street and a recipe for barotrauma. Here's a study by Laura Duggan looking at, it's a meta-analysis of studies looking at jet ventilation, and now they found a 51% complication rate in SECO using jet ventilation. And there's a high incidence of barotrauma using that device because of inappropriate use of it. Now I want to get on to some paediatric recommendations. And I just first of all want to point out that overall, 25% of the world's population are defined as children. That's 15 years or under. And in fact, in third world countries, that number rises to 40%. But unfortunately, that proportion of the population is not translated into our practice guidelines, our airway guidelines. Now, things are improving. So the more recent guidelines, and I've put up there the ASA guideline, the Canadian Airway Focus Group, and PUMA, all have paediatric anaesthetists on their panels. So they are considering children when they write the guidelines, and there is paediatric content, but it's basically an adult guideline. And when we look back at old guidelines, there are specific dedicated paediatric practice guidelines. But unfortunately, most of these guidelines are over 5 years old, and there are recommendations that guidelines should be updated in about 5-year periods. So some of these date back quite a long time, and they are due for revision. This is the DAS pediatric guideline, and you notice on the title up there, it's for children aged 1 to 8. Now, I'm not quite sure why the upper limit of that is 8, but I'm particularly concerned about the age of 1, because what happens if you're not 1 year old, if you're an infant or a neonate, it doesn't come into consideration. And this is a group that we've already heard today are prone to significant airway complications and morbidity. So we do need to consider that age group as part of our population that need guidance in terms of airway management. And in this guideline, it is due for revision, and the knowledge has marched on. This is an example of an out-and-date guideline. This is from the Neonatal Society, and they are still suggesting that a phoner in an infant should not be attempted unless there's an ENT service available in your hospital. And we've already heard today that a lot of hospitals are out of range of some of these services. So that means you have nothing to offer a baby with an obstructive airway according to this guideline. You should not be attempting management. This came out this year. That was a survey done in Germany, and thank goodness at least they disagree with that statement. Now, there is help on this horizon, and this is a combined study of the European Society of Anaesthesia and Intensive Care. It's a large panel that have been working on this for some time. They have this in early view. It hasn't been published quite yet, but it's due to come out, if not late this year, early next year, with recommendations, and there's a rescue technique pathway there you can see, suggesting rigid bronchoscopy, surgical tracheostomy, and if they all fail, ECMO. And there's going to be a lot more to it than that. I've just taken that maybe out of context, but it's going to be a new practice guideline for infants, so children 1 year of age or under. Now, I just want to talk about phoner skill decline. And I've been hearing a lot about the training that's been going on, and I must applaud what DAS has been doing. It's very impressive what's been going on around the UK, and also the efforts of Airway Leads in promoting education and training, and in the previous Cyprian's lecture on education. So I'm fully aware that this is a wonderful country for education and training. But when it comes to phoner, this study shows a significant decline after a very short period of time. So that suggests you can detect decline in skill even as short as 1 month, and certainly by 3 months you need a little bit of a top-up. And it doesn't have to be a big effort. It's something you could do within your department just to brush up on skills of an emergency airway procedure. So in their findings, emergency cricothyroidotomy was significantly improved by a simulation-based low-fidelity brush-up. Overall performance was retained for 3 months, and after that intervention was required, but some skills had already started to decline by 1 month, and skill acquisition happens without clinicians' careers, but apparently does not apply to rare procedures. So the rarer procedure, the probably more frequent you need to be training in it. Finally, I just want to give a mention to human factors. I'm sure you're all aware of two wonderful papers that came out at the beginning of this year on human factors. We all know that probably embarking on a front of neck access procedure would be very stressful. We know that when you're stressed, your heart rate goes up and your performance tends to go down. And that affects your vision, your fine motor and gross motor skills, and basically behaviour. So Fiona Kelly has offered, and her group, some advice on how to deal with that event, and there's some recommendations there in terms of breathing exercises, pre-task mental rehearsal, pre-task visualization, shared mental model, and the sterile cockpit. And of course, teamwork is absolutely critical. This is a Formula One pit stop, and the world record for a pit stop is 1.86 seconds. And it's mind-boggling to see what those guys are up to. But in that interval, they managed to pump up the car, take the wheels off, put 4 more wheels on, and also provide some fuel behind the driver, put the car back on the track, and away it goes. Now, I'm not suggesting our e-phoner should manage to do this sort of speed, but we probably should be approaching the airway a bit faster than we are when we have the need for an e-phoner. So my key points are proper preparation probably prevents poor performance, be familiar with practice guidelines and evidence-based recommendations, maintain oxygenation and respond quickly when there's a SECO event, maintain oxygenation, tracheotomy in infants and older children, and avoid barotrauma. Thank you very much.
Thank you, Paul, for that excellent presentation. Our final speaker on this session is Dr. John Graham, who represents the Australia-New Zealand College of Anaesthetists Special Interest Group. And he has come here all the way from Australia, but sadly wasn't feeling so well, so did a COVID test, and he's COVID positive now, so he's unable to be with us. The dreaded COVID raises its head again. So he is, but he has recorded his presentation, which we will show now. As I said, he's Australian and he works in the Austin Group in Melbourne, and he's been working there for over 20 years. He's an honorary clinical senior lecturer at the University of Melbourne Medical School. He's developed over the last 15 years a formal airway training progression or program for his trainees at the Austin Group of Hospitals. But his talk today is on cognitive aids and using them in airway emergencies. Thank you.
My name is John Graham. I work at Austin Health in Melbourne, Australia. The Austin is on the lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to Wurundjeri elders past, present and emerging, and all Aboriginal and Torres Strait Islander people. I have no disclosures. I'm so sorry to have come so far and not to be with you today, but thanks for listening to my talk. Why am I talking about the design and validation of airway cognitive aids? Outstanding teams of people produce excellent airway guidelines, but I fear there is a missed opportunity to focus on the design and validation of the cognitive aids that accompany their work. It is a concern that I have about my own group's work as much as anyone else's. Usable cognitive aids have the potential to transform expert content into everyday use. A quote from McClanders, a human factors academic: "User-centred design is literally putting the needs of the users at the centre of the design process." To give an overview of my talk, I will start with some discussion around the place of cognitive aids. Then I'll move on to some data from National Airway Guidelines. I'll present 2 of our cognitive aids. Then I will focus on design and usability testing, and then finally validation, which is the statistical analysis of how well the cognitive aid achieves its purpose. This diagram from Goldhaber, Fiebert and Howard depicts the potential of cognitive aids. In orange and blue at the top, they can support education, preparation, post-event reflection, and most importantly, real-time management of crises. And in yellow, a reminder that cognitive aids are most valuable in rare and refractory events, and of the value of a designated cognitive aid reader. There isn't a standard for checklist or cognitive aid development. Burien and colleagues published a landmark article in 2018 in which they described discrete and important stages that I have presented in a modified form in this slide. I will focus on design and usability testing and then validation. But all stages are important and require equal attention. From conception, when clinicians and human factors experts should decide if a cognitive aid is the appropriate response, through to the need to consider mechanisms for ongoing evaluation, revision, and possible retirement. This image, modified by Travovic and Shahania, depicts actions to improve care compared with effectiveness at achieving the change. System-level changes in red, such as culture change, forcing functions, and equipment or environmental redesign, are much more difficult to achieve, but more effective. Guidelines, rules, protocols, and policies, in yellow at the bottom, take relatively less effort, but are much less effective. In the absence of system-level change, cognitive aids in orange, with the green cross, are a person-based change that can help to bridge the gap. Embedding cognitive aids into system-level change is even more effective. A decade ago, Marshall reported that as few as 7% of clinicians use cognitive aids when available during an emergency. However, more recently, Brewster and colleagues reported that 83% of surveyed Australasian ICUs use cognitive aids during COVID intubations, suggesting that airway clinicians are ready to accept well-implemented cognitive aids during unfamiliar challenges. The reasons given for non-use are usually related to design and implementation. At the coalface, clinicians have to make a decision about whether this cognitive aid will help or hinder them in the situation they face. Okay, so in the next part of the talk, I'll move on to some of our work reviewing national airway guidelines, and then I'll present two of our cognitive aids produced with an emphasis on usability and design. In preparation for a publication, we have performed a pilot analysis. We looked at national airway guideline articles which were included in the Puma Methods paper, which covered the period from 2005 to 2018-19. We also included airway guidelines published by the same national bodies from that time until mid-2023, and the Puma paper on preventing esophageal intubation. We excluded COVID-specific guidelines. We examined each article for explanation of cognitive aid content, design and usability testing, and validation. 29 guidelines were included. All the guidelines had best practice content. 27 of the design groups were clinicians only. 26 included at least one cognitive aid. 10 described some design methodology for the cognitive aid or aids. Only one mentioned an iterative design process or formalised simulation usability testing. None performed simulation validation, clinical validation, or mentioned a specific mechanism for post-implementation feedback. There were 9 revisions of previous guidelines and 4 mentioned plans for future revision. So in summary, great content and a commitment to revision and update, but little described focus on design or validation. Now to cognitive aids. In 21-22, an extremely comprehensive guideline was launched in the UK to assist with recognition and management of neck haematoma post-thyroid surgery. The guideline included 2 new cognitive aids: the one on the left for patient assessment by bedside staff, and the second on the right for decision-making and management of the suspected hematoma. In parallel, we had been working on thyroid. Thyroid was developed over a number of years by a multidisciplinary clinical team at Austin and St Vincent's Hospital in Melbourne. Anna Phillips was the leading author. Thyroid includes early recognition, clear contact instructions, patient care, and a traffic light approach to airway decision-making. I submit that thyroid may be more usable than the UK guideline cognitive aids in crisis circumstances. I'll speak more about thyroid in the case discussions later. We have also published on tracheostomy emergencies. I wish to recognise the outstanding work of the National Tracheostomy Safety Project, and in particular their emergency management guidelines and algorithm, which was the most important content resource for our work. Austin Health, and in particular TRAMS, the Tracheostomy Review and Management Service, which was established 2 decades ago, is also a leader in tracheostomy care. TRAMS, led by Tanis Cameron and more recently Prue Gregson, coordinates tracheostomy care, management guidelines and education at Austin Health, and is a founding member of the Global Tracheostomy Collaborative. Several years ago, a multidisciplinary group was formed in our hospital to develop a cognitive aid to support the Code Blue team, which responds to airway emergencies. It was intended to complement an already existing cognitive aid developed by TRAMS for bedside staff. In our Advanced Responders Cognitive Aid, we had a number of priorities. Emergency usability, accommodating the likely variable expertise of the Code Blue teams, to use a 3-pathway model which enabled the inclusion of bleeding and was already successfully used by TRAMS, to recognise the challenges in patients with a difficult upper airway and a new tracheostomy, and to provide some guidance about the immediate use of a bronchoscope. This initial version for advanced or specialist responders was available in the hospital for a couple of years. Anecdotally, it was not used and did not meet user expectations. 2 of the authors from the multidisciplinary group, Caleb Fisher and myself, were tasked with improving usability. Out of desperation, I contacted an academic communications designer, Trevor Stretter. I suggested we needed a designer to do some artwork for us, to transform the appearance of what we had created into something that looked a bit more professional. I'm still embarrassed by the lack of understanding I had of the difference good communication design can make. Trevor joined our group in a project of co-design and completely changed the trajectory of the project. The emergency tracheostomy management cognitive aid that we have developed and published is A3 size and is 2-sided. It is normally placed on the wall above the patient's head and is taken down in the event of an emergency. This first side is for primary responders, who are the bedside staff. At the right, it also contains tracheostomy and upper airway information. The second side of the cognitive aid is the advanced responders side, to be used by the Code Blue team and in critical care environments. The first step is to check the In All Cases section at the right. The next thing is to determine which of the 3 pathways to follow. Almost always, it will be the first pathway, difficulty breathing or ventilating via tracheostomy tube. The second pathway should only be chosen if the tracheostomy tube is completely out of the neck. And the third pathway is for bleeding. Use of a title for each step next to the number with an accompanying description in the lighter background of the implications or further actions required in that step was chosen as a method to address the expertise gradient between users. For the more experienced user, the title can be used as a trigger, and for a more inexperienced team, the cognitive aid reader can provide more details. So how does the development of our two cognitive aids compare with the criteria we used for the National Airway Guidelines in the Puma Plus analysis? We are good at content and much more deliberate and at design than most others. But we have work to do on validation and feedback and also revision. Now just to signpost what I'll cover in the rest of the talk. Next I'll discuss some design principles and usability testing, which is part of design, and provide an example of formalised simulation usability testing. Then I will provide some examples of simulation and clinical validation. Anaesthesia groups embarking on design of cognitive aids are directed to the principles of aviation checklist design. Some example considerations include paper or electronic presentation, limiting content to improve usability with focus on vital items and difficult things to remember, a logical flow with clear beginning and end, clear and bold images with lots of white background, use of a sans serif, literally without feet font, a mixture of capitals and lowercase, and use of colour only if required. However, there is no evidence of a best design for healthcare emergency cognitive aids, and healthcare workers do use cognitive aids in different ways to pilots. Diverse teams are used in high reliability organisations to design checklists and cognitive aids. It has been suggested in healthcare that psychologists and designers should be part of design teams with expert clinicians, frontline staff, and human factors experts. Decision-making during crises is interesting. Initial management of the crisis will likely be well underway before a cognitive aid may be available or referred to. Recognition-primed decision-making is a rapid, almost unconscious decision-making process based on matching the current circumstances with previous experience. It has been suggested that this approach is used at least initially in the majority of airway emergencies before an analytical approach. A very didactic cognitive aid at the early stage may increase cognitive load, decrease situational awareness, and slow decision-making. Linear designs are thought to be easier to remember and interpret than branched algorithms. Sampling has been described by Burian's group. They have observed that medical users often interrogate checklists for additional or specific information. And they have designed cognitive aids to enable this to be done more efficiently. Usability testing is part of the iterative design process. Design is followed by usability testing, which is followed by design in a cycle until improvement ceases. Usability testing is relatively easy to do and should be done early and often. It shouldn't be left until those last final adjustments are made, as there may be much larger problems not yet recognised by the designers. Most problems can be detected within the first 3 to 5 users. At the most simple level, usability testing involves watching and listening to users interact with the cognitive aid. What appears obvious to the developers may not be so obvious to users. Questions in mind for developers should include: is it possible to use it? Is it being used in the way we expected? Is it more or less trouble than it's worth? A multi-layered usability testing approach has been adapted from health information technology work. It begins with an individual in isolation and works up to formalised simulation usability testing. A really important point. Good design is crucial. It will be improved by usability testing, but usability testing can't rescue an initially very poor design. Usability testing must be preceded by and be followed by good design. McIntosh and colleagues undertook formalised simulation usability testing in their design of a new local anaesthetic toxicity manual of cognitive aids. They started with 3 existing cognitive aids which they had observed in use in simulation. Their anecdotal experience with these cognitive aids was that users made errors with lipid emulsion dosing, sometimes in the order of magnitude of 10 to 20 times. They did 5 simulations with aid 1, followed by a structured debrief, and asked for suggestions for the design of a new aid. With the help of these suggestions, a prototype was developed. Then, after 5 simulations each, with aids 2 and 3, further feedback was sought on the developing prototype. Finally, simulation was performed on the prototype, now called aid 4. The correct dose of lipid emulsion was given in 4 of 5 simulations with the new aid 4, compared with 2 of 15 simulations on aids 1, 2 and 3. So they had produced a manual of cognitive aids. The table of contents is on the left of the slide. Page numbers are chosen according to weight. The 80 kilo page is on the right of the slide with an exact dose of lipid emulsion rather than needing a weight-based calculation. The Harvard group used simulation to validate their operating room crisis checklist manual. They randomised groups to manage operating room crises with and without the manual. 17 teams from 3 hospitals performed a total of 106 simulated crises. There was a 4-fold reduction in missed key points of care. And every team performed better with checklists. Clinical validation is harder and is performed in different ways. McGrath and colleagues from the National Tracheostomy Safety Project have demonstrated that a package of improvements, including introduction of emergency algorithms, has resulted in harm reduction and a reduced number of incidents in tracheostomy patients. And from major trauma resuscitation, Fitzgerald and colleagues from the Alfred Hospital in Melbourne fitted half of their trauma rooms with large screens, providing action prompts to team leaders. The action prompts are derived from clinical algorithms and incorporate the patient's vital signs and clinical story. They perform video analysis of real-time clinical trauma resuscitations and showed a reduction of error in the groups using the prompts. This is an image of the large screen in the resuscitation room. The action prompts appear in the coloured boxes on the screen at the top right. This is an example of cognitive aids being part of an environment redesign. So in summary, development of cognitive aids is a comprehensive process. Historically, there has been a focus on content in National Airway Guidelines. In this talk, I've focused on the importance of design and usability testing and approaches to validation. However, all stages are important, and development requires teams of people with complementing expertise. Thank you. These are the QR codes to our 2 articles. 50 copies of each of our cognitive aids are available for those who are interested.
Thank you very much for some excellent talks in this session. Unfortunately, we are just short of time in this session, so the speakers will be available during the break. So if you have any questions, you can really ask them during the break. Thank you very much, everyone.
Thank you very much to all of the previous speakers and chairs. Thank you all for being here this afternoon for one of the most exciting keynotes, to my mind at least, because I think the topic is very, very important, and we are blessed and honored to have Malin Johnson Fagerlund here from Sweden, Karolinska Institute. So this is summertime weather for her, I think. Malin is an associate professor at the Karolinska who's done a huge amount of work in a wide range of areas related to respiration. She's an expert in ventilation, respiration, and she's done a lot of the work in apneic oxygenation that we've all read about, and we may or may not have changed our practice secondary to the work that she's done. I could talk for a very long time about Malin's work, but I think that she is going to be able to speak about that for herself. So without further ado, I'm honored to introduce Malin to the stage. Malin, thank you very much.
Yeah. Thank you for that kind introduction, and I would like to thank the organizing committee for the invitation here to the DAS meeting in Birmingham. So the title of my talk today is Apneic Oxygenation, Why, When, and How. And how many of you are using apneic oxygenation on a daily basis? Do you use prolonged apneic oxygenation? Yes, thank you for the light. Prolonged apneic oxygenation? Yeah, there are a few. Great. So I will take you through apneic oxygenation and pick some of the key papers and some reflections. And here is a summer picture of Karolinska Institutet. Nowadays it's like this much snow, it's very nice, and minus 10 degrees in Stockholm. It's fantastic. So I actually think it's quite warm here. So apneic oxygenation, why should we use it? I think the major reasons would be to extend the safe apnea time and also to have a tubeless anesthesia. So is apneic oxygenation something new? No. So Robert Hooke described in 1667 respiration without respiratory movements. And thereafter, there were a couple of centuries without so much about apneic oxygenation. But then in the mid-50s, we had Martin Håsson Holmdahl, who is a professor in Uppsala in Sweden. He did his thesis on pulmonary uptake of oxygen, acid-based metabolism and circulation during prolonged apnea. And there were a lot of studies at that time, and there was some great interest in apneic oxygenation in the mid-50s. But the excitation about apneic oxygenation, there were some problems here, as you can see. You can see the patient numbers and the duration of apnea, up to 55 minutes. And there were no problems with oxygenation. But if you look at the arterial PCO2, you can see very high numbers here, up to 33 kilopascals, almost like some of our COVID patients. And that was, of course, unacceptable. So the excitement went away until this landmark paper came out, 2015. There will be a 10-year anniversary next year for this paper, Anil Patel and Reza Norey, who brought apneic oxygenation into the operating theater, because I think that many of us has been using it in the PACU, in the intensive care unit, for neonates and so on. But this was a case series in patients undergoing anesthesia for difficult airways, and this really changed a lot for many of us, I think. And they quoted the acronym THRIVE, so I just, for those of you that has missed this, I just want to explain that this is apneic oxygenation using high-flow nasal oxygen. And some of the figures from the study, you can see that oxygen was well maintained during extended apnea. We also even had a patient here at 65 minutes with good oxygen saturation. So oxygenation doesn't seem to be a problem. What about the rise in carbon dioxide? That was a problem in the 50s. Well, there is a rise in carbon dioxide, of course, with time, but the rise was lower compared to previous studies. It was 0.15 kilopascals per minute. And if we plot that into the old studies from the 50s here, you can see that the rise in carbon dioxide was much less. And that is promising for the use of the technique, of course, because then you can have your patients apneic for a longer period of time. And after an early communication during the DAS meeting 2015, I think, in London, my colleagues came home and we did this study where we did apnoic oxygenation in patients undergoing laryngeal surgery in Stockholm at Karolinska. And this was adult patients. They were pre-oxygenated using Thrive, 40 liters per minute, 100% of oxygen. And then they were put to sleep using TIVA. And the oxygenation after apnea was 70 liters per minute, 100% of oxygen. And the airway was patent using the rigid laryngoscope, as you can see here. So the surgeon had control of the airway. And if you look at this figure, you can see there's some very unusual thing for an anesthesiologist, I think at least until now, that we don't have any end-tidal carbon dioxide on the monitor, no flow curves. It's quite unpleasant the first time you look at it, but then you get used to it and it's okay. You need to have some kind of monitoring. We had transcutaneous carbon dioxide monitoring, we had an arterial line, and we were doing blood gases, as you will see. The mean apnea time in this study was more than 22 minutes, and none of the patients had a desaturation below 91%, and the mean SpO2 was never below 98%. We also, of course, had an increase in arterial PCO2, and that was very similar to the increase in transcutaneous CO2 that seems to be very feasible. We were quite skeptical about that method, but it seems to be working very well. However, the end-tidal rise in carbon dioxide was 0.12 kilopascal in comparison to the arterial rise that was almost double. And probably the study from Patel, there were a lot of end-tidal carbon dioxide monitorings. So this number, the end-tidal increase, is more in line with that study. And as you can understand, there was a subsequent respiratory acidosis as well, and we had a stopping criteria at 7.15 of pH. So what is the safe apnea time then? Is there anyone who knows? Well, that depends on in which situation you are. I think many of us have been in the COVID pandemia. Intubating a COVID patient, you don't have any time at all. You are at minus from the beginning. This is my younger brother. He's a Swedish championship in breath holding. He can hold his breath for 7 minutes and 15 seconds. It's quite ironic, I think. I still haven't done the studies on his friends, but there will come some, I think. So I don't think that's a safe apnea time at all, but it's very hard to define. I mean, it depends on the context, of course. Here's a Danish study exploring the safe apnea time. They were investigating patients undergoing orthopedic surgery, and before the intubation, they kept the airway patent for approximately 27 minutes. And you can see that there were no problems with oxygenation, but the carbon dioxide was rising and the pH was declining. And you can see after 20 minutes or so that patients are stopping to drop out, and one patient managed to be apnoic up to 45 minutes. And the rise in arterial carbon dioxide was 0.25 here. So what about this? Then these are some of the studies done. What about desaturation during apnoic oxygenation? Have you seen that? Yeah? So it exists. It's not like a wonder method as everything. So you have to be aware of that patient can desaturate. We did a few studies after the first study, and we saw that patients with higher BMI, former smokers, maybe lung disease, high metabolism, and so on, they can desaturate. So it's important to have a plan B and C, and you can't just solely rely on the apnoic oxygenation. So what about PEEP effect? Could that help? Do we get a PEEP effect using high flow and apnoic oxygenation? Yeah? Yeah, maybe. That depends. Here's a nice study from Bern in Switzerland, where they ran in a crossover randomized trial, investigated the PEEP effect. And what you can see is that if you have the mouth closed, that is the red dots, you will get an increase in PEEP dependent on the flow. But if the mouth is open, like when you're doing rigid laryngoscopy and so on, there will be no PEEP effects. That's quite logical, but it's good to remember that. Yes, so after seeing all these studies, we were speculating together with the rest of the world, I guess, if we had some more time when doing RSI anesthesia, maybe we could, if we run into trouble, have 25 minutes instead of 5 to 10 minutes before the patient desaturates. And we know that emergency anesthesia have a high risk of hypoxia. So high flow nasal oxygen during rapid sequence induction, and this is an old picture. We use video laryngoscopy at Karolinska nowadays. I have to apologize for that. This is from our trauma bay, where I do most of my clinical work. But there is a couple of clinical studies on rapid sequence induction using high flow nasal oxygen and apnoic oxygenation. And what these studies tells us is that it's at least equally effective, and you can speculate that if you run into trouble, you will probably have an increased time before desaturation. We heard this nice talk about obstetric anesthesia this morning, and I will just highlight these papers that we heard about. This is the EGA paper of the effect of high flow nasal oxygenation in pituitants. This is from China. They had 17 patients in each group, and you can see that there were slightly higher end-tidal O2, and in addition, the arterial PO2 was higher in the patients pre-oxygenated with high flow nasal oxygen. We have a study from Turkey. It was Egypt. This is a study where they also compared high flow with traditional face mask, and you can see that the safe apnea time increased and the arterial PO2 increased as well. And we did a small study in Stockholm. Most of our patients, I guess it's the same in UK, will have regional anesthesia for cesarean sections, so these are really rare patients. So we decided to have one group of 25 patients with high flow, and those patients that didn't want to participate in the high flow trial, they were controls. And what you can see is all the patients had a high, no one was desaturating, but the lowest end-tidal O2. We had 3 red patients here. This is a traditional face mask, and here is one high flow patient. So obese patients, is this a valid, good method for obese patients? Yeah? So we have a few studies on obese patients as well. And you can see that safe apnea time is increased using high flow in morbidly obese patients here. And this time could be quite valuable in case of problems. We heard a little bit about this study as well this morning, apnoic oxygenation in the morbid obesity, the BJ study, where they had 80 patients, and they were apnoic for 18 minutes without desaturating below 92%. It was more common to desaturate in the face mask group compared to the high flow group. So I think the result of this study was quite surprising, but they had, as you heard, a very ramped position, so it was a good positioning. What is important to realize that if you are doing high flow on obese patients, there is a greater risk and a shorter safe apnea time compared to patients with a lower BMI. Here is the difference in BMI at 40. So what about children? Are you using high flow in children? Apnoic oxygenation? Those of you that are doing PEDS? Yes, good. So there are some PED studies as well. These are one of the first pediatric studies from 2017. This is also from the Bern group in Switzerland. They've done a lot of nice trials. 60 children with the age 1 to 6 years old and a weight of 10 to 20 kilos. And they were randomized to low flow, 100% of oxygen, 0.2 liters per kilo and minute, or Thrive, high flow, 100% of oxygen and 2 liters per kilo in minute. And then another Thrive group with just 30% of oxygen. And they had the termination criteria, desaturation below 95%, transcutaneous carbon dioxide above 8.7 kilopascal, and an apnea time over 10 minutes. So you can see that both groups, both low and high flow, seem to have approximately the same apnea time. But if you decrease your oxygen, the FiO2, from 100 to 30%, you will have a shorter apnea time. They had the same rise in transcutaneous carbon dioxide of approximately 0.6 kilopascals per minute. And this study, approximately the same time, came another study in the BGA, 48 healthy children, 4 age groups, and the primary outcome was time to desaturation to 92% transcutaneous O2, and there was a control group and a high flow group. And you can see that with a high flow, you get a longer apnea time before desaturation, but the rise in arterial or in transcutaneous carbon dioxide is similar, independent on flow. And I think when these studies came out, I thought that, well, maybe this is PIDs. They have a high metabolic rate. Maybe it doesn't work in PIDs. So how is it with adults, the ventilatory exchange? And here again is a nice study from Bern, Switzerland. It's Thomas Riva. Single-center non-inferiority trial with 5 groups of 25 patients. They were randomized to minimal flow, 0.25 liters per minute in the ET tube, or low flow, medium flow, and high flow with jaw thrust, and a control group with 70 liters per minute using laryngoscopy, just to make sure that they had a patent airway. And the primary outcome was a linear rate of mean increase in arterial CO2 during 15 minutes of apnea period. And as you can see here, there is a similar increase in carbon dioxide in all 5 groups, and there are 25 patients in each group. And the primary outcome is the increase in carbon dioxide, the linear increase during 15 minutes. It's approximately 0.25 kilopascals per minute. So it seems like differences in flow rate does not affect the clearance of carbon dioxide as we thought. So maybe it is more that previous studies from the 50s had different types of anesthesia. We have lower the metabolic rate on the patients, so on. So if we would like to investigate this further, how do we investigate extreme physiology? We can do, of course, data simulations or so on, but we can also go to animal models. And in Stockholm, we had a stable animal model where we were investigating cardiac arrest, and also a model of COVID where we infused the pigs with angiotensin in order to mimic RAS overactivation. So we used the pig model in this study. 9 pigs were anesthetized and they received muscle relaxants. And as you can see, we have this rigid laryngoscope, and we have the nasal cannula in the snout, the large one. You have to hold it a little bit to make sure that it works properly. And then we tested 10 liters versus 70 liters per minute during apnea. And we aimed for an apnea period up to 50 minutes. And the pigs they had a PA catheter, we had radiology and so on, so we could do extensive studies on this. And as you can see, the oxygenation was not a problem up to 50 minutes. We did PaO2 and we looked at the venous side as well. The red ones are the high flow and the blue ones are low flow. So, but this was surprising for us. Flow is important, of course. For the 10 and 70 liters per minute, they could go up till 45 minutes. But the pigs were pre-oxygenated for 5 minutes before we started the experiment. But if we took away the pre-oxygenation and no flow, these pigs will desaturate quickly within 3 minutes. So that is really tells us how important it is to use some kind of flow. If you don't have a high flow, machine. You probably have like a normal nasal cannula, this thing you put into the nose or something. You need to have some kind of flow, because otherwise you can create problems for yourself. Also, in this animal study, we did not see any change in the rise of carbon dioxide between low and high flow. And we also wanted to look at central hemodynamics in this study. And you can see that the carbon dioxide, you can't see it, it's supposed to be a small gray line there, but with increase of carbon dioxide, you get excessive central hemodynamic effects. And that implicates, of course, that we have to be careful with our patients who have compromised circulation maybe. And there's also a radiological image before the experiment, and you can see that the enlargement of the heart after 45 minutes of apneic oxygenation and a high arterial PCO2. So what is an expected increase in carbon dioxide then? Well, I tried to summarize a little bit the recent studies. Here is the old studies, and here you can see we have adult patients with end-tidal carbon dioxide. Here we have arterial and venous carbon dioxide, and up here are children and young animals with a high metabolic rate. So it seems like we're probably somewhere here for adult patient, and it doesn't seem that flow is really doesn't really take away the carbon dioxide, a higher flow. So the rise in carbon dioxide is dependent on apnea time, anesthesia, patient factors such as BMI, age, FRC, and also oxygenation. So I think, although I think all of us were very excited about the ventilatory exchange, I think that we now can accept that we probably doesn't have so much of a ventilatory exchange, but we have a great oxygenation, and we have apneic oxygenation in the operating theater, and I think it's very helpful for us. So when can we use apneic oxygenation? Laryngeal surgery, avoidance of lung and body movement, for example, ablation of liver tumors, for example, instead of jet ventilation, during apnea, before securing an airway, difficult airways, emergency airways. We heard this morning that the emergency airways are not harder than the normal airways, but I still think in some way maybe we do something wrong in Sweden, but it seems to be more challenging. One lung ventilation, diagnosis of brain death, and finally, but not least, education to buy time when you educate a resident with your video laryngoscope securing an airway. So how do we do it? Pre-oxygenation is important in order to wash out the nitrogen. So pre-oxygenation with nasal cannula, 3 minutes, 100% of oxygen is very important. All the studies trying less oxygen, it seems like that's not such a good idea. The airway needs to be patent all the time. The flow could probably be between 50 and 70 liters per minute. And the duration is dependent on the factor that we were discussing, the patient and the context. We need to monitor carbon dioxide for longer apnea times with transcutaneous carbon dioxide, arterial, and also you can take venous blood samples in order to follow the trends. Education is very important, and it's also important to realize that apneic oxygenation is not a replacement for good airway training, and you need to have a plan B, C, and also D, of course. So this is not a rescue method. Important factors are oxygenation, carbon dioxide, time, education, and in EGA they highlighted this. It's important for safe use of apneic oxygenation, patient factors, equipment factors, and team factors, because this is a highly advanced method, and you need to know what to do and what to do if something fails. Gap of knowledge, we need to know more about the mechanism, limitations, we need larger trials, most of the studies are quite small. And in summary, apneic oxygenation, 100% of oxygen, we need a patent airway, measurement of carbon dioxide during prolonged apnea. It's not a rescue method. Oxygenation does not replace an airway plan, and you should be careful if you're doing laser. Of course, this is not recommended. And finally, I'd like to end with a quote from a Swedish skier, Ingemar Stenmark: "The more I practice, the more lucky I get." Thank you.
Thank you very much for that, Malin. Very, very insightful run-through on pretty much everything that we need to know about apneic oxygenation. In fact, I was thinking about that. I don't think there's anywhere on the planet right now where there's more knowledge about apneic oxygenation than this room right here, right now, because we have everyone who actually has done the work, including those presenting on apneic oxygenation. So what we'll do is we'll take just a couple questions from the audience before we break for coffee. So if anyone has any questions, please make your way to the microphone. Whilst the first person does that, I do have one question myself, Malin, which is, and I kind of been thinking about this, and a few of us have been talking about it. We're very focused on the airway and the lungs, and the airway and the lungs in terms of apneic oxygenation and the efficacy of apneic oxygenation. Not really thought that much about the heart. And I know that we were talking about, and you mentioned in the paper that was published on patients with obesity, one of the key things that they did in that study is, yes, they sat the patients up, yes, they expanded the FRC, but also they all had vasopressors running. And I just wonder what your thoughts are on the role of cardiovascular impact on oxygenation and ventilation.
Yeah, I mean, those are, of course, close together, so it's a very important question, and I think we need to address that more, because in the studies that has been done, that hasn't really been addressed, so we need to do more studies on central hemodynamic, investigating the patients without cardiac ultrasound, maybe some kind of cardiac output monitoring and so on, in order to understand which kind of patients that this could be applied to, because obviously an increased carbon dioxide on a fragile patient with cardiac disease could end up in disaster, of course. So you need to be careful what you're doing.
Thank you.
Yeah, hi, I'm James from Portsmouth. I just wondered, I've always wondered, does surgical laryngoscope position affect effectiveness of, well, it's not Thrive now, but high flow nasal oxygen apneas? For example, if the surgical laryngoscope is right up against the larynx, is that an issue you've ever observed or not?
No, and I think, I mean, as long as you have a small free airway, it will be okay. What can happen with the surgical instrument is that it can be a kink to the nasal cannula, and then you're in problems. But when it comes to lower down in the airway, it usually works if you have a free airway.
Thank you.
Thank you.
Yep. I'm really sorry. Would it be possible? Are there roaming mics? No. If not, would you mind just coming to the microphone just at the front here? We're not watching you. Make your way to the mic.
Hi. Thank you for your talk. In my centre, we do quite a lot of paediatric airway surgery, and we do use the laser. I've been using an apneic or sort of high-flow nasal oxygen with a spontaneously breathing patient. And when they do the laser, we have an air blender, so we can turn down the percentage of, the proportion of oxygen that we're giving. Is there any, so it's almost like an intermittent 100%, 21% technique. Is there any information on that? Would you deem that safe in terms of avoiding airway fire?
I mean, there are no studies on that, of course, but there is a risk in that moment, and there are occasional reports of airway fire, and we actually had one in Stockholm as well. So it could happen. So you have to be very careful.
And that's even with a lower concentration of oxygen.
Yeah, I think so. Yeah, and I think maybe Anil Patel, do you want to comment on that, because that's what you do every day?
Anil, would you mind? And we will watch you walk to the microphone, because...
Yeah. So I think, I don't think we should use any form of ignition source with any form of oxygen, be that with a blended mixture of air, oxygen, or just oxygen on its own. And the reason is because we have ingrained in our brains that when we do lasers traditionally with a tube, we have a relatively low flow of air or air oxygen or air nitrous oxide mixtures going through because it's going through a ventilator. And we have equated, and the literature tells us, that if we drop the FiO2 with that low flow and a laser hits the piece of plastic, then our inflammability index and our chance of having a laser ray of fire is lower if we have a lower FiO2. The difference with high flow is that you're not using a low flow, you're using a really high flow, and you're delivering a lot of oxygen molecules over the same period of time, and therefore your flammability index is increased. So using a blended lower FiO2 with high flow is probably a bit safer than just using 100%, but it still doesn't make it safe. It still means that you can still have a potential in airway fire. I don't think we should, there aren't really the studies that back that up, but just from first principles, I think that's useful. And probably the best way I think you can illustrate that is if you go camping and you want to produce a fire and you have a few embers, you blow air, you blow over that and it catches light and it produces a flame. You're not blowing high FiO2, you're just blowing air. It's the number of molecules that are going across which is also important. But we've never really looked at it from that side of things. We've only ever looked at it as a tube, relatively low flow. I drop the FiO2, that makes the difference. So I think we should look at it in both aspects, both FiO2 and flow rate, and I think they're additive and both important. Sorry, that was very long-winded.
No, that was brilliant. I told you, nowhere in the whole world will you have more knowledge than in this room right here, right now. We have time for one more question, and I think we'll go to James, and then we'll break for coffee.
Thank you very much for your great talk. I also use Thrive, but just in your picture, we talk about flow, and that flow determining PEEP, and PEEP being the determinant of your apneic oxygenation duration. So no PEEP, no duration prolongation. However, in the surgical picture that you had, the patient's mouth was open. Yep. They're having open mouth surgery. So with the mouth open, it's difficult to generate the PEEP despite the flow. So the question is, again, we magically managed to do these things in places of excellence of ENT hospitals and so forth with laryngeal surgery, but the mouths are open. That's my only kind of quandary here.
Yeah, we actually did a study like in 2018 or something like that when we were looking at the lung volumes with EIT, comparing mechanical ventilation with high flow Thrive. And it didn't seem to be any difference in lung volume. So, I mean, it seems to work without the PEEP effect. You have such a high flow, but according to the studies, we don't have that pressure in the lung because it's obviously open, and it will be open in all types of airway surgery. But, I mean, if you use it for pre-oxygenation, difficult airway, and so on, you can try to close the mouth. And actually, it seems like it's more comfortable for the patients if they are awake during pre-oxygenation to have the mouth closed compared to what we might believe.
Thank you very much for the question. Thank you very much, Malin, for your talk. I thought that was absolutely fantastic. We'll be breaking for coffee now, and when we return in about 20 minutes. Thank you, Malin. Thank you.
Thank you.
See you in 20 minutes, please. 20 minutes.